Hey, and welcome back to another Tuesday training. Hello, hello. I'm so glad that you guys are here. We are diving in today for another Tuesday training for practitioners where we meet every week to talk client work and functional anatomy and orthopedic resolutions to the pain that I believe none of us should live with. We all get to be out of pain, and that's what we're here to do. So thank you so much for joining me. For those of you, here's Gary coming in. Lori, I'm glad that you're here live in the club seats as well. Gary's coming in. I'm going to make sure I can see everybody on YouTube. Also, if you guys are watching with us while we're streaming live on YouTube, welcome. I'm so glad that y'all are here. I love having you guys every week to talk shop with. Hey, Gary, I'm glad that you're in the house. It does take just a minute for, I guess, for YouTube to populate. So you guys, I'm recognizing that as soon as we go live here in the club seats, it takes kind of a couple minutes for YouTube to go live. I don't know if you guys here, Lori and Gary, are watching on YouTube, but I'm figuring out all the tech as we do production backstage. So thanks for being here, wherever you're joining. I'm happy that you're here, happy that you're in-house. We are going to have, I think, a fun time today talking client work, chief complaints, typically where we like to start our questioning. Like, do you know my client has this? What do I do about it? We're going to find out. And that said, I want to know what your clients are coming with too. If there happens to be part of the symptoms list that I'm going to go through today and share with you that I believe are all, I don't believe, I have experience knowing, I know, and I believe that they are sacrum-centric. If I don't quite touch on one of the symptoms that your clients are presenting with, bring it up. Let us know in the chat. If you're here watching on YouTube, type it into the chat. And if you're here, obviously live, let me know. We're going to go through, let's see, 1, 2, 3, 4, 5, 6, 6 different chief complaints today. In addition to the 2 that we went over 2 weeks ago. Don't worry about the numbers, but we're going to do a hearty handful. That's what the point is. And so I want to make sure that I cover everything that you guys have questions about. That's the whole point that we're here. So if you're here and you're watching live, let us know. Type it in the chat. Let me know that you're here. Obviously, Lori and Gary, I see that you're here. I love that you're here. And chief complaints is, I don't even really like the phrase chief complaint. It's like, I'm the chief and I'm complaining. But the point that we mean by chief complaint is, what's the main thing that's bringing your person in? And we said this a few weeks ago, that the onset of that chief complaint probably happened as a lower toned, quieter, almost whisper way before the chief complaint became raging. It's really rare that folks will come in and say, it's really nondescript. I really feel okay. I just don't feel 100%. So I took time out of my day and my schedule to come in and see you to see if you can find something that's nondescript. It's pretty rare that folks come in with that. And yet, in those moments, if we can return them back to remembering those moments, that's a big piece of the puzzle. It tells us when it all started, what was going on, and what were the state of affairs, meaning like state of alignment affairs. So do your best to recall that with your clients while you're, doing your subjective intake and find out what those moments are. We don't want to make our client, I always say this, we don't want to make our clients wrong for not coming in during the preventive stage or during the, I feel 98% but not 100% stage. We don't want to make anybody wrong for that. We just want to remember to go looking there. I don't want to run to the doctor or the practitioner every time. I'm not 100% either. I kind of trust that things are going to work themselves out. So, keep that in mind. They're not wrong if they get to you and they can't quite explain it or if it's been a while. All right. So we're going to move through, like I said, several different chief complaints today, and I'm going to walk you back to where it all starts. And this focus for today is when it starts at the sacrum. And, you know how I be, sacrum-centric, it's almost always tied back to the sacrum. So we're going to work through as many of those today as we can. And I'm going to walk you through the steps on how I find them and how you can find them as well. I have a special request for our pin it to win it activity for today. And that is, rather than pin to win it in our normal phase of pin to win, I have a heartfelt request for all of you who are here. And that is that I am, some of you know, some of you may not, I am in a competition right now for the Entrepreneur of Impact. And my intention in that competition is to not only get all of our clients and all of us up to par to get all of our clients out of pain, and I'm on a mission to do that and give us a lot of focus on that. Drug-free pain relief is the way we all work and way we know it can be. But I also want to win the competition so I can increase programming for all of us. So it matters to me to be in the running. It's not usually my thing. Like I'm not like hey, I'm in first, vote for me. I'm not that girl. So this is a big vulnerable stretch for me to be out here doing the thing. And so, oh, Lori, thank you. And so my request is that rather than doing pin it to win it, if you all would please cast your votes. I have until Thursday to be in the top one, and then it goes on for several other rounds after that. So this is a big sort of pressure cooker 48 hours for me, and votes count as double today. So if you are on socials, if you have a Facebook account, you get to vote for free. Votes count double for today, and that is my deep request that we play pin it to win it to Gina and first so that we can all win. So thank you in advance for that. Lori just posted the link here, and let me see if I can switch over to YouTube and get you guys the link there as well. Welcome back to another Tuesday. Let me see if I can do that. This is definitely high-end production for me to be switching between screens. I have one laptop, guys. So let's see if that showed up. It did show up. How cool do I feel right now? This is definitely me spreading my wings and going beyond my comfort zone. So if you are here in the club seats, Lori put that in the chat. And if you are joining us on YouTube, we have that in the chat for you there as well. So thank you so much for clicking that link and clicking the vote box. All right, back to programming, shall we? Get back to our business at hand, our other business. All right. Sacrum-centric is the conversation for today. I see some more of you have joined us live on YouTube. Thank you for being here. I love that you're here. Let us know that you're here. Put your name down in the chat and definitely comment along the way if these symptoms, chief complaints, are something that you've navigated or are currently navigating so that I can speak into them for you. I don't really want to just be here sort of talking at you and listing it out. I really want to share information that's valuable to you. All right, so here we go. Murph is excited to be also front camera today, just like his human. Sacrum-centric is our focus for chief complaints. And one of the most common chief complaints that we get when the sacrum is the genesis of the problem is low back pain. Low back pain. And sometimes they'll point to like a general area here. Sometimes clients will hold on to their side, sort of lower backish. And sometimes they'll point a line directly across the top of the ilium. You've seen this, Gary. I think you've mentioned this actually in a training before. Hey, Perry, glad that you're here. So when we have low back pain, and I don't want to get too general and renegade about it, you definitely get to do your due diligence and figure out with the person that you're with and the body that you're serving, what's actually going on. Some things to consider, though, is what I'm going to offer you today. And it's really easy for these general condition, chief complaint areas to be tempting to work on because it's like, oh, there's so much meat here. There's so much muscle to go through. There's so much for me to handle here. And we're going to use what we know about the body. 90% of the pain in the body is referred from somewhere else. We just keep saying that over and over and over again. I used to say it was 80%. Chuck Duff taught us that the science now says it's 90%. So the number just keeps growing since I was first in school, which just means like, listen to that. It's rarely where the chief complaint lies, right? They're pointing here, they're holding here. It's compelling, but don't let yourself get compelled. Let yourself use what you know. 80 to 90% says can't be here, but it can be the sacrum. And largely, when it's lower backish, like lumbar 3, 4, 5, largely the sacrum is a high contender here because of its juxtaposition to the L5 disc and the L5 vertebra. Ooh, the lighting in here today. We have a very overcast, grayish, but bright kind of day coming in the window. There, you can see the vertebra now. So in our Sacred Sacrum course, we talked about this at length. This meaning the alignment of L5 in its neutral position is not stacked like an Oreo cookie. So I've said before that, a visual that you could use when you're thinking about the spine is to think about it like Oreo cookies. The vertebra being the cookie shell and then the disc itself being the white stuff in the middle. Love this. Don't love Oreo cookies because they're not healthy, but I like the cookie visual for the vertebra. That said, we know that we have curves in the spine. We talk a lot about the four curves of the spine, and this particular vertebra down at the very bottom of the vertebral column in its neutral position is at a very deep angle. Look at that, right? It's even, a deeper angle than the others that are part of the apex of that curve. It's just this really steep angle. And so we workshop this out in our Sacred Sacrum course about how do you navigate that alignment of that vertebra and how does it get into trouble so frequently. And we talked a lot about sitting and seated posture, and we did some workshopping and worked all that out on how to correct that. For today, what I want to just remind us, though, is that this alignment of this vertebra in its neutral position and its juxtaposition, meaning right next door to the sacrum, means that while this vertebra can get into trouble a lot from our posture and patterning and the way we sit and the way we do things, it's also needing the neutrality of the sacrum to stay at that angle if its neutrality is also at an angle. So it can absolutely be activity that we do at the lumbar spine. It can also be alignment that's occurring at the sacrum that also challenges that needed position to be, I don't even know what angle that would be, like 30-degree angle it looks like maybe. I mean, it's been a while since I took geometry. So keep that in mind when you're navigating low back pain. Two things we already covered. Tempting to go with all the meat and all the muscles and all the possibilities and all the ways we can dig and get responses. But we know that the law of the body that tells us about referral pain, that there's only really a 10% chance that that's going to resolve it. So as we look deeper into the structure and we have a sacrum-centric approach, we can see, you know what? That alignment of the sacrum matters here. Because if this vertebra is out, all of the muscles in this area can be symptomatic. And we're talking chief complaint here, right? The alignment of this bone means its alignment as the base of the axial skeleton and its curve, and also its alignment in relationship to the other two bones in the pelvis that it juxtaposes. We already talked about L5 as one of them in the axial skeleton. What about the appendicular skeleton in the hips? Which then brings me to chief complaint number 2, which is really common, SI joint pain. How many of you have navigated SI joint pain? It's pretty much like we're all doing that. And if you guys are here on YouTube, let me know, are you navigating SI joint pain? I was thinking about this morning as I was getting very excited to come meet with you all today. I was thinking about this morning and how common it is for us to, as practitioners, to be enrolled in this idea that the SI joint is a problem. The SI joint is the problem. The SI joint is the problem. Let's take a workshop on the SI joint because the SI joint is the problem, because you really need to know the SI joint is the problem. And like how many times I've heard that in my career. And you know how I am about this, guys. Like I don't vibe well with like pointing at a body part and then like blaming it like it's a bad guy. I just don't vibe well with that because it's not. It's literally giving us a house to have this amazing experience on the planet with. I don't understand the throwing it under the bus. I just don't get that. And so like, where does that all come from? That's where my mind was going this morning. Like, well, where does it come from though? It's not just fear tactic. It's not fear mongering. It's not just drama for drama's sake. There's legit SI joint pain. And ironically, I had a little sensation in my SI joint this morning. I was like, gee, you gotta like have integrity around what you're going to say here. And I do. So hear me out. Still, the law about referral pain matters here. Just because I'm having a sensation in my SI joint doesn't mean that that's where it's coming from. The joint, the joint, the joint, the joint, even with all the workshops that we've all been invited to participate in, because I know that the referral pain math is still 90% of the pain is referred from somewhere else. So then how do we get our mind around it when it's not a muscle and it's actually a joint? And we might be more compelled to think, well, the 90% thing only matters when it's muscles. This is resonating with you, Gary? Yeah. The 90% thing only matters when it's muscles, but joints are a different beast. No, they're really not. They're different in the way we approach them and the tools that we use to remedy them. But the source of the problem is still 90% chance of being somewhere else. So if we're talking SI joint pain, and I know I can't blame the joint, then what else could I look at? Well, you literally could look at the sacrum, even though the sacrum is half of the SI joint. But doing that allows you to just address what the sacrum needs rather than mistakenly thinking there's a function inside the joint that needs to be fixed, like the ligaments, right? Think about it like this. Ligaments connect bones. I was going to say ligaments are connecting ligaments. Bones are connected by ligaments. We know this because we know our anatomy. So if we're actually going to blame the joint, what we're mostly considering as body workers, because we're not orthopedic surgeons, what we're mostly considering then is the ligaments between the joints. But I ask all of us, how many of us are actually here to release ligaments? Please say no. Even if you're a PT and you learn the names of all the ligaments, our role as body workers, manual or movement practitioners, is not to release them unless we're absolutely sure that they need to be targeted, like we talked about one of the ligaments last week. But as a general rule, we don't want to go after muscles and just start releasing all of them anyway. We've talked about this a lot here, as I've talked to you guys about tension types. Only one of them really says that that type of tightness should be released. So if I'm only 25% of the time releasing a muscle, which has elastic qualities in it and contractibility in it, if only 25% of the time would I be releasing a muscle, why would I be releasing ligaments as a regular practice? Please say no, because it doesn't, the anatomy is telling us that that doesn't make sense. It's not my opinion. We're using what we know about anatomy to answer this. So back to the SI joint. When we have SI joint pain, we don't want to start focusing on the joint like the joint is the problem, because what we're saying then to ourselves and our client is that there's something going wrong in that joint, and the connective tissue between those two bony structures that create that joint are what need to be targeted. And that's not true. It's not true, because the problem mostly with joints is the alignment between the two bones that meet to make that joint happen. So it's not that I need to focus on the joint. I need to focus on the alignment of the two bones that make that joint. Okay. And that, if we just think about it in that way, it might seem simplistic, but literally it changes the course of action of what you're going to do here. Okay. Was this landing for you guys? Is making some good sense? Yeah. How many of you have been enticed by an SI joint workshop? Is it just me? SI joint? Perry, how about you? And anybody else here on YouTube? Anybody been enticed by an SI joint pain workshop? Let's figure out the SI joint. Okay. I want to enter here a thought, and that is, when we're learning something new, and this is true for us and for our clients, when we're learning something new, it has to go through our brain first, obviously, until we can like own it as like an owning. And when we create new information to bring into the brain, one of two things happens. Either we have no idea what's being said and we just completely reject it, like Teflon, just falls right back off. Or we can reflect it with our mirror neurons to make it look like it's something else, because that's how we can make sense of it. The brain doesn't have lots of new information. It's just the way the nervous system takes in data. So at this juncture, if you were someone who was working on SI joint pain and you're still trying to mull over what I just said, because it's not actually clicking with a mirror neuron on how you work, you might be feeling like you're just going to reject what is being said, or you might actually be feeling sort of like a little disgruntled with it, you know, like I don't think she's right. I don't know what she's talking about, but normal. It's not about me, by the way. I'm good with that. It's not about me. But this is what the brain does when we're being challenged with new information. The key to learning is to walk through the challenge all the way through to the end. I just talked about this with my practitioners this week. It actually releases dopamine in your brain when you walk through the challenge. When we are rejecting the challenge and we're like, no, she's full of crap. I don't want to talk about it. or I'm just not going to pay attention anymore, you're actually not feeling good because there's no dopamine release in your brain. It's fascinating, right? We don't think that there's a feel good like chemical reaction when we're feeling challenged. I usually like to think that I feel better at the end of the challenge, but the truth is it's the strive that creates the dopamine release. Isn't that magical? That our bodies were created with this. You get to go and grow and evolve and experience life to the fullest, and I'll help you feel good while you do that. Isn't that freaking magical? Like, I want to know that person. Like, who made me? Because that's brilliant. Smarter than me. Okay. So if you have already up until this point been working through, let's say, for example, SI joint as a joint, and you're like, no, Gina, I do functional stuff at the joint. My invitation for you is just open up your ideas to what if you didn't work the joint? What if you just did a little bit wider of a view on what's possible? Because our reason for doing that isn't to have me be right and they be wrong or whatever. It's not about that. It's I want to resolve it. I want to resolve it. So I don't know about you, but I got really tired quickly of clients coming and feeling better when they left. And then the next time I saw them 2 or 3 weeks later, they'd say they only felt good for a couple days. And they didn't come back in a week, even though they didn't feel good, because in their mind, it didn't really work. It helped, but it didn't work. I want it to work. Like there's no assignment that says we have to be in pain perpetually. I was just listening to a video also today that we've really gotten accustomed to just chronic illness as a way of life, just to be generally low grade, feeling bad, highly medicated as a way of life. Where did we adopt that along the way? That's like boiling a frog, slowly turning up the heat until we don't even realize we're in the boiling water. It's not meant to be like that. And the same is true for pain. So my invitation for you to widen your lens right now on what could possibly be creating that SI joint pain isn't to make anybody else wrong or any other, idea or approach invalid. It's to resolve it permanently instead of just make them feel good while they're there with you or for a couple days afterward. Okay, so let's move on now. Sacrum-centric approach, chief complaint commonly, hip pain. Now, hip pain is really interesting because if you ask your clients where they think their hips are, and don't do this because this is kind of shitty and it puts them on the spot because they don't know their anatomy, but they'll point like to here, like where, like their side a little bit. Sometimes they'll even point to their back pocket. And also sometimes they'll think their back pocket, they'll refer to their back pocket as their back. So we don't want to like challenge them on their anatomy. Guys, we're still learning ours. Let's be honest. Sometimes we still don't know body parts. So we don't want to be, confrontive in that way. But hip pain, if you're somebody who takes, for example, written consent or written intakes, where's your chief complaint for today? And your client writes down that it's hip or on their appointment, for example, you got to really qualify where that is. Not because they're wrong, because it's vague. What we know hip pain to be, if we're just looking at the anatomy, this is the hip joint. This here, where the acetabulum and the femur meet, this is the hip joint. So anything else is specific to the innominate and muscles that attach there and stabilize it. So if we're down here and we're in hip pain, we have different muscles that do 360 movement. If we're up here and we're in hip pain, we have stabilizing muscles. That's a different approach. Yeah, the stabilizing muscles that would be around innominants would most likely be in duress, again, because of the alignment of the bone, the innominate, to its adjacent bone. I'll say it again. The reason for muscle chief complaint here, not hip joint, but hip area, again, 90% of the time is not a muscle here. But if a muscle here is giving us symptoms, the reason it's giving us symptoms is because of the alignment of the bone it attaches to and the alignment of the bone it's adjacent to. And that goes for not only the muscles here on the innominate, if you're thinking glute med and TFL and the like, not only these muscles here on the innominate adjacent to the sacrum, but also the innominate adjacent to the other innominate. So the misalignment can be here and still coming from the sacrum. If this bone is out of alignment, it affects the two bones on either side of it, which then articulate with each other here. So we want to, again, this is straight up, by the way, using our anatomy. It's using, I know what the bones are. I know what the joints do. I know that the muscles move the bones at the joints. I know what the joint action is. I know that 90% of the pain in the body is referred from somewhere else. Boom. You lay all that anatomy out for you. And then you can get into, well, what happens when some of that isn't working, right? So, yeah, curtain number 3, we call it. So I'll reveal more about curtain number 3 as we move forward, probably next few weeks. Okay, so that's the areas that I want to talk about down here that are sacrum-centric. And now I want to move into shoulder pain. How many of you have ever had here live with me or also live with me on YouTube? I see you guys here. How many of you have ever had a client come in with shoulder pain and you knew that it was connected to the sacrum? Or how many of you have had a client come in with shoulder pain and you recognized that it might be related to the sacrum? Or how many of you have had a client with shoulder pain and you're like, never in my life would I have ever thought it was sacrum? Any of those is okay, because that's cool. That's why we're here. I just actually had a client recently who swore he had shoulder pain. In fact, he said that he had wrist pain that he suspected might have had to do with his shoulder. And again, it's tempting. It's tempting when the clients are clear and the symptoms are strong and they are kind of moving fast. They want you to result. It's tempting. Remember your math. Remember your math. It's only 10% chance that it's actually in his wrist. Only a 10% chance. That includes his hand, by the way. So we trailed along and looked for things. And in the shots method, I measure the sacrum heartily, sacrum-centric, of course. I need to know exactly what this guy's doing in the body. And his sacrum was way out of alignment. And I thought, well, if his sacrum's out of alignment and his wrist is hurting and the common joint in between them is the shoulder joint, how much do I think this is in the shoulder versus in the sacrum? Well, sacrum-centric, I'm like, it's definitely got to be sacrum. But here's how a sacrum-centric genesis can then show up as shoulder pain. Anybody know? What's the common that connects the sacrum to the shoulder? What's the common anatomical part that connects the sacrum to the shoulder? Anybody?
Are we dealing with the 4 curves here?
Good approach, Gary. You know I'm happy about these approach. That's lovely. And I'm going to give you a clue that we're talking about muscle. But yes, in order for us to talk about muscle, we have to have 4 balance curves first and foremost. Perry says, these days I always look at the pelvic region when addressing any issue. Oftentimes it has something due to his COM. What's COM stand for, Perry? COM. Something.
Motion.
I don't know what COM means. Type that out for us, Perry. What's COM mean? So we're talking, the question on the table is, what's the connection, direct connection, an anatomical part that connects the sacrum to the shoulder? Sacrum to the shoulder.
Is it the aponeurosis of the lat? Yeah.
Yes, ma'am. It's lat dorsi, which is a shoulder muscle. And the aponeurosis literally covers the entire sacrum and a little bit of the SI joint and the lumbar spine. So to your point, Gary, yes, the lumbar curve, all 4 curves, center of mass. Okay, Gary, Perry, yeah, awesome. Center of mass. Center of mass, sacrum-centric. I don't think we're talking about the same thing, but close enough to be in the same area. Sacrum-centric here. So the aponeurosis here, I have an image for us. For those of you who are like the who, what? How's the imagery? Yeah, the lighting. All right, so you all recognize this as lat dorsi, right? It's pretty wide, broad, very superficial, meaning close to the surface of the skin, not superficial because he doesn't mean anything, muscle that is a shoulder muscle. It's a swimmer's muscle. He works the shoulder. We never think about him with low back. We think about him with the joint action that he does. And that would be fine because we are following our principles of anatomy. What's the joint action? What muscle does the job? And let's figure out if he's doing his job. Totally cool. Or you could say center of gravity. Yeah, Perry, get it. But if you look at the origin and insertion, origin being here and insertion being here of this muscle, the origin does have movement in it. All muscle origins have movement in it, but insertion has more movement. That's how you can tell what the joint action is based on the insertion. If it inserts here, it does more movement here than it does here. Fine, even better, even more plausible about what I'm about to share. That said, there is still some movement in the origin of the muscle, and both the origin and the insertion are very densely connected. There are tendons there, but look at the size of this little tendon. Look at the size of this honkin' tendon. What the who? Wow, that is a lot of tendon, which just tells us, because we know the nature of tendon, that it has a very necessary stabilizing, grounding, all the way down to, as Perry's calling it, your center of gravity, your axial root, if you will. That's where it has to be rooted for all this movement up here to occur. It's a shoulder muscle. Okay. Now, I don't typically tell us to go after muscles just based on where they originate and where they insert, because that's not always the answer. But the nature of where they originate and where they insert, the direction of the fibers and the nature of where they originate and where they insert. Now that all starts to tell a story. And we do dive deep into that in Muscles and Movement. It's really a worthwhile climb, I think, for us to know that about muscles so that we're not just arbitrarily picking a muscle to sort of wrestle with during our session. So if we look at the nature of lat dorsi and the broad band of tendon that's here, that would let us know that it requires these bones to all be in alignment for this muscle to be anchored and stable in that place. You see that? We talked about this in our lever system masterclass last spring. In order for us to get maximum gain out of a muscle, the bones that muscle connect to must be in alignment or there isn't maximum use of the lever, which then tells us the same thing is true for all things that muscles need bones for. Stability, anchoring, movement, contractibility, they all require that the bones be in alignment. So as you said, Gary, like before balanced curves, yes. And then once they're balanced, what's now the connection between a shoulder problem, shoulder injury, limitation in my ability to move my shoulder, and that would be in both extension, which the lat dorsi does, and its opposite, flexion, because both sides of the lever require that a muscle be available to do both actions, its action and its opposing action. We're just using the anatomy to walk us through the solution here, right? So that muscle now needs to be both lengthening and contracting equally. And his opponent or his playmate, actually, there's no opponents in muscle land. And it requires that the sacrum be stable, aligned, and balanced so that the lat can do what it's supposed to do at the shoulder. Now, most of us, I believe, even movement providers, by the way, so manual providers overlook lat dorsi. Understandably, I did too for a long time. That's why I'm sharing this with you, because I figured it out. I overlooked it for a long time, and movement practitioners overlook it too, believe it or not, because we just don't do that much extension of the shoulder, right? Unless we're like interlacing our fingers behind our back and, doing something like yoga does that even more than Pilates. And even personal training. We have personal trainers in our mastery program too. And they're like, yeah, I guess I don't do that much shoulder extension now that I think about it. So we don't get that much airtime with lat dorsi. So we forget that he's not fully available. So we miss that shoulder action in flexion needs lat dorsi in extension to be available for the lever to work. And he can't do that if the bone that he anchors to is out of alignment. So back to the client that I recently had, he was complaining of wrist pain. His shoulder seemed fine. He didn't have any pain with shoulder movement, but his sacrum was out of alignment. And guess where he had adhesions? In his lats, because he was doing lat pull downs, but not shoulder extension while he was working out. A lot of them. Lat pull downs are called that for a reason. Okay, I'm now just seeing the sacrum with the shoulder and lats. Totally cool. Oh, good, Perry. I'm glad the penny's dropping. I love this. Great. All right. So now, so don't overlook the lats now. All manual and movement practitioners, trace that baby. And the cool thing about where he lives, being so superficial and directly under the skin, is you can really trace him pretty easily. Of course, if you're a manual practitioner, you get to do that. If you're a movement practitioner, don't do that. Don't start just crossing the lines of your own integrity around what you're licensed to do. Stay in integrity and find other ways to explore the lats if you're not a manual practitioner, okay? Just make sure that we're keeping ourselves clean, good clean karma. All right, next one is hamstrings. So we're back to common chief complaint, tight hamstrings, tight hamstrings, tight hamstrings. How many of you have clients who say they have tight hamstrings? Show of hands, 100%. It's a crowd pleaser. How many of you have clients who say that they have tight hamstrings and you believe them because they can't go into hip flexion and touch their toes? Come on, we've all bought into that. We're like, oh yeah, he really does have tight hamstrings. He really can't reach his toes, or she, right? I don't know why I always say he. So we've bought into that as well. And we talked fully last week about how I'm telling you guys, don't blame the muscles, right? The muscles are only responding to the bones they're attaching to. So if you want to workshop out in your note-taking ability how we addressed hamstrings last week and their relationship to the sacrum, please go do that because it's a worthwhile venture. Again, we're back to the alignment of the sacrum matters so much of the time when the chief complaint is tight hamstrings. Absolutely. So don't take the bait and start working on the hamstrings and stretching the hamstrings and PNFing the hamstrings. You'll be busy, you'll seem talented, but you won't really resolve it. And then you'll feel bad about that at the end of the day. I know you will because you guys tell me that you do. Now, I'm not putting that on you. I don't want you to feel that way anymore. I really want you to win. I want your clients to win too. All right. Then, interestingly enough, downstairs from the sacrum at the feet. Now I know Murph's legs are longer than this, but for, film purposes, down here at the feet, how many of you have clients who complain of foot pain or calluses or corns on their feet, or they wear extra things inside their toes because they rub and all kinds of, okay. Really tempting to think it's their shoes. How many of you have clients who complain of foot stuff, who are constantly buying new shoes or getting the shoe experts to fit them, or getting lifts or inserts inside their shoes, or asking their podiatrist for extra band-aids for their corns or whatever happens? Okay, just like my clients, I totally get it. We're going to go back to our law. The law of the body tells us that 90% of the pain in the body is referred from somewhere else. Yeah, but Gina, a callus is a real callus. It's not like phantom pain. Oh, I get it. However, our feet were made as divinely as the rest of our body. There's no reason why our feet should be in such distress just from walking. Well, but Gina, the shoes don't fit and they're not good quality and toes get squished and you're not thinking straight. Okay, I got it. Except that, how many of those clients switch up their shoes? How many of those clients have pain in their feet even when their shoes aren't on? Okay, so then it's not the shoes, guys. It's compelling. I get it. You're like, well, it rubs right there, right where I feel my toe fitting in the shoe. I get it. And if your shoes don't fit, your shoes don't fit, and you shouldn't do that. However, what's a more probable solution to the genesis, not just symptom smacking while they're there, blaming the shoes, is if the sacrum is off in any way, and the innominants that are adjacent to them are off and they would be if the sacrum's off. They're either off because they're in their rightful position and the sacrum's not in its rightful position, or the sacrum's not in its rightful position and it took the innominants with it, and now both are not in their rightful position. What that means then is that the femur that requires for the innominate to be in alignment is no longer articulating the way he's designed. And guess what's taking in all the impact from the earth? The foot and ankle. The other way around, let's say the innominate's fine, the femur's fine, but the sacrum's a little out of whack. We know because of the design of the sacrum as the keystone of the entire structure, that if the sacrum is not sitting in its optimal aligned position, the weight distribution right to left will be altered, and then the foot will still hit the ground differently, right foot to left foot, even if the innominate didn't go with the sacrum out of alignment. Either way, it's sacrum-centric that causes most of the foot disparity. Disparity? Symptoms? I don't know what word I'm reaching for words here. Disparity? Gary, you're going with that? Thanks. And I will tell you how I found that. The way I found that was in my own body. Every time my right innominate and my right SI joint have just a little tiny whisper of discomfort. Not like I'm going to get body work, but like that initial, hey, you might want to pay attention. Every time that happens, if I don't do something about it, within 3 or 4 days, notice the window of time, my left second to last toe, my 4th and 5th toe on my left foot will start to ache. Every single time. And I missed it myself for a long time because I broke that toe. So I used to think, oh, maybe it's tied to the weather. Maybe it's this, maybe it's really compelling, guys, to like follow the symptoms and just let the symptoms tell the story. The symptoms don't tell the story. The symptoms tell part of the story. But your savvy and your anatomy prowess, after being here with me all these times, lets you know to look in other places. And so I'm telling you, we just walked through. It's not because my body told us, although it did. It's because we just walked through it. If this sacrum is askew, the keystone is off, the weight distribution changes in the cathedral. And if the sacrum's off and the innominate goes with it, the articulation of the femur can't be level on one side versus the other. We just walked through it. It's just basic structural math, right? And we do talk about this. I should also offer this. We do talk about this and workshop it out in our sacrum course. We walk through all of these symptoms and all of the architecture, the cathedral that I just mentioned, and we workshop it out. So we give you, we work through some data, get clear understanding around it. And then the next training, we workshop it. What do I do about it? Where do I put my client? So you have good notes, lots of clarity, and you have absolute accurate workshopping also while you're in that course. And the course is live right now inside the club. So you guys have until the end of February to just grab that course for free. You can just go in there and take all 16 hours of it and also meet live with our anatomy advocates who will help workshop it out with you and answer your questions. You don't have to go it alone. You don't have to gobble the whole thing up. They'll meet with you once a week. I'm in there every day. The rest of the community is also in there workshopping out stuff. And of course, we workshop it out and then I'll ask you a question to take you to the next spot. But we don't hang anybody out to dry there. It's very supportive and you'll get your answers quicker if you workshop it out with somebody whose intention is to get you to win. So that's what we're doing there in the club. Again, Sacred Sacrum is available throughout the rest of the month. So this is our last week doing Sacred Sacrum. It's included in the club. If you've never been in the club before, come and hang out there for a week as my guest. There's no obligation to stay or pay. You can just come for a week and just see if you like it. We have the Sacrum course happening right now. The next course for March is launching again. We're throwing that in there at the beginning of March. That's this coming weekend. We also have challenges in there and replays, of course, and extra guest speakers and all kinds of extra fun goodies in there to keep our head in the game. So please feel free to join us. And that's all included in your membership. Okay, so the only other symptoms, chief complaints, common chief complaints that tie back to a sacrum-centric view are herniations and sciatica, which are super, super common. And again, we did dive into that with some focus here in Tuesday training last week. We talked about herniations and sciatica and hamstrings. We also talk about them, of course, in the Sacred Sacrum course, and then we workshop out what to do about them. So far today, we covered sacrum-centric being the genesis for low back pain, SI joint pain, hip pain, shoulder pain, hamstring pain, feet discomfort, herniations, and sciatica. I mean, guys, it's the sacrum. It's the sacrum. It's the sacrum. It's always the sacrum. Okay, so I've done a whole lot of talking, and I know you guys have been patiently listening. I still see you guys here on YouTube. Thanks for being here. Now I'd love to open up the conversation for you to ask me any questions that you have on client work. Maybe there's a chief complaint I haven't covered, and you're wondering if it's sacrum-centric, or if you thought it was sacrum-centric and you approached it and still are looking for results. Any questions that you guys have. I'm here until the questions are answered. Anybody have a question for me?
I was giggling when you said you thought it was the weather. We think it's the weather. We think it's our shoes. We think it's the way we sit. It's our pillow. It's our mattress. It's everything. Like literally everything except what the body is telling us. It's so
Literally.
funny.
Literally everything. Yeah.
Yep.
Again, it's one of the reasons why I'm on such a mission to just get all this information out, because in my experience, it's really simple. It's not easy. Like, I'm not saying that we're, not needed or well educated or well trained. It's not easy, but it's pretty simple. It's pretty straightforward. And even when our clients have the information, they still can't do their own body work. So they still need us to, we're all interdependent by design. So if they were more clear on their own symptoms, because we were more clear on the symptoms and we openly shared it with them, then they would come sooner, be in pain less, and we would have an easier time solving it, because it wouldn't have stacked with all the patterning that comes with it when they wait and don't come. They change their mattress and their pillow and their shoes for months before they come in, instead of listening to that little whisper. So yeah, I want to pour into you guys so you can pour into yourselves and then pour into them, and then they can pour into the people around them, and then boom, the world's pain-free. Wouldn't that be great? I mean, it is great because it already exists. We're just going to make it a reality here. Okay, my friends, any questions? I'm looking in the live chat. You guys have any questions for me? You guys are very thoughtful. Gary, what you got?
I'm not sure how valid this is going to be, but I was speaking to another massage therapist, and she was asking me a question. She said, I have a client who wants me to work on groin muscles because he rides a bike, a stationary bike with a group for 35, 40 minutes every day or every other day. And when he gets off the bike, he has these pains. And so she was asking me, what do I think this is? And and she said, well, I think it's psoas because it's only on the left side. And I said, well, it might be, first thing I said is it might be the sacrum. The sacrum be out of alignment. And I said, just think of the position. This person is, 35, 40 minutes, shoulders down, head forward, sacrum back. And I said, in terms of so she works on the psoas, it's fine for a week, and that, it's exactly what you're talking about. And so my comment was, if it seems to be only on one side, then it's probably the innominate is off and the sacrum is. So what I said, what are you having him do when he gets off the bike to do any kind of rebalancing, because he's in a very awkward position. Well, I wouldn't say awkward, but the body will um, absorb what it needs to, but it'll talk back. So I'm not sure if my advice to her was going in the right direction or not. I mean, because it
Hmm.
wasn't my client.
Okay. So your question is, do I think you went in the right direction?
Yeah.
First off, Gary, I'm so proud of you. I'm like, yes, you did. And she knew enough to know that you could support her. So that's awesome. And you did support her, equally awesome. And we probably want more information to give her exactly what to do. However, you gave her really good guidance. Here's what I heard. The client, wants the muscles that are symptomatic to be addressed. Because again, clients don't know that the sensation is not where the source is. Say sensations in the stretch when you're talking about the lever system, but the sensation, AKA the chief complaint, it's only a 10% chance that that's actually what needs to be addressed.
Right.
So you did great with that. And the other thing that I heard was that it was only one side.
Mm.
So the interesting thing about a cyclist is that they're literally using both lower appendages equally. Now, he's
Right.
not a stationary bike, so maybe he's not. But the way I like to think about it is if you weren't using your legs equally to pedal the bike, wouldn't you be riding around in circles? So if you didn't ride around in circles, there's a better chance that you were using your legs closer to symmetrical than what your symptoms are now stating,
Hmm.
if you were aligned. And so
Right.
you pegged it, Gary. So if there's a misalignment, then you aren't using both sides equally because you can't. We talked about that. If two bones are not aligned, and the muscle that attaches to them is doing the work, he can't fully do his work if the bones that he attaches to aren't aligned. It's not possible. They go offline a bit. Some of the fibers can't contract.
Hmm.
And again, you were at that master class. So I love that you pegged that because that's what we talked about in our lever system master class. So if it's only one side, first of all, it needs to be the lever system that needs to be addressed, but it's only one side of the body whose lever is unhappy doing the exact same activity that the other side of the body is also doing, then it's probably an axial misalignment. And that would, yes, absolutely take us back to the sacrum.
Hmm.
Really good job. I'm super proud of you.
Okay. Thank you.
Yeah, absolutely. Now the question is, what did she do about it?
Yeah.
Is she going to come? Was this recently? Is she going to come back to you and give you a report?
I spoke to her yesterday, and I don't know when she's going to see him again.
Okay.
Um, he's she's beginning to be uncomfortable working in the groin area for a long period of time, and it's still not resolving the problem. So,
Sure.
yeah,
Well, those two things are very compelling. If you're uncomfortable working there, don't.
right,
And if it's not resolving it, you shouldn't bother. That's
right.
the epitome of Groundhog's Day. It's that thing that we keep working and keep not making solutions. So either in those instances, um, your client's higher knowing knows that you have the answer or are about to get the answer, and that's why they're
Mm.
hanging out because people don't
Mm.
like to waste their time or their money. So if it wasn't really working, him coming back means that he probably thinks she's going to get the answer.
Well, or like a lot of our clients who are just used to having temporary fixes and temporary fixes and temporary fixes, and that's the behavior they're in because they
True.
don't really know that anybody can fix it.
That's true. And that,
Or yeah, or what you said earlier, Gina, about we're used to living in this low level of discomfort. Oh,
Yeah,
and blaming the muscle or yeah,
Mhm.
all of that.
Right.
Yeah.
And we're just going to use the anatomy to solve it. Right. So it's literally what you did, Gary. You used the knowledge of anatomy to help solve the problem for her or to support her in solving the problem. And that's what we get to do. So maybe it's an invitation for her to learn more anatomy too, so that
yeah.
she could piece that together, right?
Mhm.
And then communicate to the client. It doesn't need to be a temporary fix.
Right.
Mhm. Beautiful. I love
Thank
this.
you.
Yeah,
Have her
sure.
come to Tuesday training.
Yeah.
Have her come to Tuesday training.
Hmm.
Invite her,
Yeah,
Gary, for sure. She's welcome. Okay.
okay.
Hey, Kathy, I'm glad you're here. If so many symptoms are requiring realignment, isn't it something that can be resolved by chiropractic treatment without the need for massage therapy? Also, if I need realignment for myself, good. Isn't that interesting? There's like this big heart on the screen and I can't read that word. For myself, good night, benefit from going to chiropractic, I know and trust. Okay, can't quite make out what the last part of that was, Kathy, but here's the deal. And I love this question. Realignment is probably a confusing term because chiropractors align bones, they adjust bones. They adjust joints, actually. They adjust joints, which are made up by bones. But muscles move the bones in and out of alignment. So what's missing in chiropractic, well, what's beneficial about chiropractic is that they do high velocity, high impact. They get two bones who are not agreeing with each other, who are in a locked, like I picture it like locked horns in like antlers or something like locked horns. Urgh. Only a chiropractor can get those two things to come apart without breaking the antlers. We are not trained to do that. When that's needed, there's no other skill except that one. And then when you get into like specialties like upper cervical, where they can adjust, the base of the occiput to get to C1 and C2 that no manual therapist can reach, there's nothing better. However, what's missing in chiropractic is they don't address the bones, or excuse me, they literally address the bones. They don't address the muscles that move the bones. That would be a manual or a movement practitioner, which means that even when the antlers or the horns are unlocked from each other, the muscle patterning that happened when those muscles weren't able to move during lockdown of the bones, those muscles have now patterned to not actually fully do their lever system job. And that's not restored just by disconnecting the horns that are locked, depending on the time. Like if you just knock yourself out of whack today and then you go in and get an adjustment this afternoon, there's not a lot of time for muscle patterning to really like create a problem. But if you've had a bone issue for quite some time, and the muscles around it have now decided to compensate and recruit and turn off and turn on harder and do all the things that they do, the chiropractic adjustment's not going to fix that. That still has to be addressed because those muscles move the bones. And if those muscles are still in a pattern of the misaligned formation of the two bones, those muscles will then pull the bones back to where those muscles are now patterned to be. So it's at least both chiropractic and manual work. And I know for me, I manually work and get bones to move all the time without using high velocity and high impact because I address the muscles that move those bones. And then when it's needed and I can't get to it, like a C1, C2 experience, I can't get there no matter how talented my hands are. Well, then it's the right place to partner with a provider that does that. I hope that answered your question, Kathy.
I think you also, the chiropractors that are woke always have massage therapists in their office.
Mm-hmm.
Very, very common thing.
It is very.
I don't know how they're directed. I haven't worked with a chiropractor before, but I think they know that.
Some of them do, and some of them, it's just a really good business model. And I don't mean to be cynical, but I worked with 3 of them.
Ah,
And the one that had the most woke, as you're talking about, that wasn't just, so they could bill for massage and get a lot of money for that time. It's a 15-minute block for insurance. They can get a lot of money for that time. They pay the massage therapist for an hour. They give the massage therapist 2 to 4 people in that hour, and it only costs them what they make for one of them. So they're making a whole bunch of extra money and then keeping the massage therapist gainfully employed because they're busy all day long. So if that's a business model that a chiropractor is using, that doesn't work for me personally for obvious reasons. And the most woke chiropractor that I worked with, it was very interesting. They get just as competitive as the rest of us, which is just really got to go, guys. Like we can't be competing with each other. It just doesn't work for the bigger vision. But we were navigating someone who had who had lung surgery. So their rib cage had been, down the sternum cracked open. And as you can imagine, there was a lot of soft tissue that was around that area. And she would come in regularly for chiropractic adjustments, but the bones would not always like reposition themselves again because of all the patterning that happened in the scar tissue, et cetera. And with his work and with my targeted work, she finally had an opening after like 18 months of being just with him. And she had only been with me for, I think, 4 or 5 sessions. I'm not better than him. I just had a different approach to what her body needed. And I could have only done that if he had done his job. But she had this like huge opening and was in tears and was like, called us all out to the desk and was like celebrating. And I can't believe it. My life has been changed, blah, blah, blah. He got so competitive and jealous about it. He's like, I don't know what you were doing, but I didn't hire you to do that. I'm like, first of all, you didn't hire me. I'm an independent. And we just gave this woman a life's experience that like, what the hell? There was a challenge. There was like, I don't know what you did, but I wasn't there doing it, So the woke ones can also be competitive, just like we can be. And you guys, like, don't freaking do that. Just don't do it. Just keep training until you can get the results that you want, or be grateful that the clients you have are getting the results if you're actually vision driven and not pocket driven. So maybe that's why we're body workers, massage therapists are working in chiropractic offices, Gary, but that has not been my experience yet. But I'm open to being wrong about that and having that have been changed. Okay, my friends. Any other? Go ahead, Gary. Go
Thank
ahead,
you.
Gary.
Yeah.
Oh, yeah. You're
Yeah,
welcome.
thanks for your comment. Yeah.
Yeah. You're welcome. I feel like I could write a book just on my work experience, not even on the anatomy. I just don't know if it would, like,
Who's going to publish it?
yeah, I don't know if it would contribute. I mean, it would be entertaining, but other than just being entertaining, if it's not going to contribute, I'm not really interested. So yeah, that's one of the good news about me being in, fully fledged for a few decades. I feel like I've seen almost all of it. So I've been around for a bit. Okay, my friends, it's been such a delight to talk shop with you today. Thank you so much for your attention and your contribution to the conversation. Thank you also for your votes. I can't wait to see what the results are. I really appreciate you. The link again is in the live chat, and also it's here in the chat here. Thank you so much for supporting our cause. I feel like when I win, we win. So I appreciate you guys supporting me in that. And I look forward to seeing you guys next week for more Tuesday training for practitioners. You guys have a great week. Bye for now.